They are clinical vignettes, just a snapshot of what we experienced. And we saw two very interesting cases, which I just want to share with my colleagues. Right, so we have a 36-year-old female presented to A&E with a sudden onset postcoital headache, which was worsening over the last 24 hours. It's associated with some photophobia, vomiting episodes, and it was sudden onset. And she described the severity as quite high, rating it up to 9 out of 10. There was some initial presentation, periorbital pain, neck tenderness, and she described the headache was all over her head. And she also described history as having migraines in the past and was currently on oral contraceptive pill. So on initial clinical assessment, they couldn't find any neck stiffness. There was no rash, fever, or any neurology, no respiratory symptoms, no joint aches, or rest of the body examination was fairly unremarkable. Investigations, chest X-ray was nil acute, showing nothing consolidation. And bloods did have only raised white cell count of 12, but CRP was within normal range, and the rest of the bloods were unremarkable. So just for my colleagues and junior colleagues, so what would be your most important and immediate investigation in this scenario? Yes, those who have guessed right, we should get a CT head, which we did. So I'm just sharing some clips of CT. There are some artifacts. Let me know if you guys want to go back any slice. Ventricles look fairly normal size, no midline shift there. So CT was reported having no acute intracranial abnormality or hemorrhage, normal and enhanced images, and no radiographic contraindication for LP as they normally are reported. So what's the diagnosis here? And does she need any further in-hospital management? So patient was transferred to one of the outlier medical wards, and the plan was to discharge her the following day as her pain was settling and discharge her with analgesia. It was because she was describing this episode as similar to, however, more severe episode of her migraine. So when we saw her in the ward, she said that the pain has settled a lot, but still she feels agitated, and there was a lot of anxiety in the patient. She didn't have any more photophobia, no further vomiting episodes. There was no fever. Orbs and bloods remained stable throughout her stay. And as I said, patient described this very similar to her migraine headache, but she said this is a bit more severe and it's more protracted course than her previous episodes. So what's the working diagnosis here? Is it one episode of headache? Shall we call it an severe episode of migraine? Shall we get a neurology opinion, outpatient? Is there any other differential we're thinking? So let's talk about this primary headache associated with sexual activity. PHASA, FASA, I just found out from some of the articles. There's very limited literature review on it, any review article on it. There are some studies which have been done with patient count of up to 50 or less than 100. And in literature, mostly it's been referred as postcoital headache or coital cephalgia or benign vascular sexual headache. Actually, I was just going through another article in which they mentioned in which patient having postcoital headache with complications, they labeled it as malignant vascular sexual headache. And initially, there were variations of this, which they recognize as pre-orgasmic, and it's actually pre-orgasmic cephalgia and pre-orgasmic headache. And two subtypes described in literature were pre-orgasmic, having a dull onset, usually bioccipital, pressure-like aching pain all over the head, and which increases with mounting sexual excitement, or an orgasmic sudden onset, explosive onset of pain just prior to the moment of orgasm. But it's just a variation of postcoital headache, if I may put it that way, or FASA, whatever you want to call it. Both are managed in a very similar manner. So regarding pathophysiology, there have been some speculative theories about the pathophysiological mechanisms. One of the investigating articles proposed it can be related to excessive contraction of neck and jaw muscles during sexual activity, and hence he proposed it might be avoided. And it was seen in certain patients that their incidence of recurrence was reduced with relaxation of muscles. Um, and then during those articles, they refer to this subtype as having a primary exertional headache, a similar variant of tension headache or variant of migraine, if you put it that way. In other articles, it was attributed to rapid increase in blood pressure and heart rate related to autonomic, and also described it as a reversible cerebral vasoconstrictive syndrome. So how common is it? And in your opinion, which gender is more affected? So in those studies in which I was going through, the exact prevalence, obviously incidence is unknown, but in the published studies, it's usually more common in males, a male to female ratio of 2.9 to 1. And in 2/3 of patients, they present with bilateral headache, whereas only unilateral in 1/3 of the patients. What about your clinical encounters? In fact, I've actually encountered about 4 such similar patients in the last 3 years, and all 4 of them actually, incidentally, females, not males. I wonder why is that, whether males do not present with that or they think it's whether it's a misdiagnosis in those patients. So the workup-wise, the differentials for this headache is for any, just like any the subtype of headache, like CVA, arterial dissection, and subarachnoid. Although there was some distinction made on UpToDate saying that unlike primary sexual headache, the headache related to subarachnoid has a very typical neurological symptoms, neck stiffness, possibly involved with loss of consciousness, and is generally more protracted. But then the presentation can be quite mixed or variable, actually. So you can't just pinpoint that these features are present in subarachnoid and not in postcoital. The acute treatment, which has been shown with success in literature, is sumatriptan intranasal spray. And preventive to prevent the episodes of sexual headache, they have found a success with indomethacin. Obviously, you need to make sure there's no cardiovascular history for that patient, and propranolol. The dose can be increased up to 240 milligrams a day with success in many patients. But what's a chronic course of FASA or headache with sexual activity? So one of the big trials, it was reported that 75% reported only single attacks or single bouts of sexual headache and never had it again, whereas 25% reported a chronic course of ongoing headache episodes. But even among those who had a chronic course, after treatment, the remission rate of 69% was almost 70% was achieved at 3 years interval. So are you happy with the management of this patient if we send her home with analgesia and support? Because she is no more having photophobia, and she's quite she says that this is very similar to her migraine episode, and that's what was one of the reasons I brought this case, because in such patients we can miss such red flags and the diagnosis which requires some further investigation, which we did. We did follow the CT with an LP. It was a clear CSF sampling, and the microbiology did report a slightly blood stain. The report of the microbiology and biochemistry was slightly delayed, and but however, we found out there was no culture growth. However, the spectrophotometry did show there's increased bilirubin and oxyhemoglobin, which was consistent with subarachnoid hemorrhage. So naturally, we went back to radiology and rediscussed that scan, and an addendum was placed. There was a missed diagnosis there. There was a small focus of hyperdensity in the anterior falx, measuring about 8 millimeters. Let me just show you that slice again. So if you notice here, an immediate neurosurgical referral was made and a discussion with Brighton. She was commenced to nimodipine and blue lighted, and which after being accepted by the neurosurgical team, and patient was transferred. So what are the learning outcomes here? I'll just hand over to Dr. Coles here, just to have a discussion.
So thank you, guys. This is quite a very interesting case that we did, and it's very important for us, all of us, to learn that, it's always good to take our time and go through our differential diagnosis. And in this case, we did take our time, went back to the patient, asked a thorough history and clear things, re-examine several times, and then obviously proceeded to the LP with the patient's agreement. And when we did find out that this patient have a potential bleeding, we immediately called neurosurgeons. In fact, the neurosurgeons also alerted us that, look, there's a bleeding on the scan that we saw, and we went back and rediscussed. So at the end, this patient have immediately been accepted, and the neurosurgeons, once they saw the scans, just blue light the patient, and we will handle her. So it's important for us, obviously, a history taking, re-examination, and confirming. I think the importance of listening to our patient, and also trying to understand what's going on. So I think this is the most important learning outcome in our case here. Any questions for that? Okay, if there's no questions, we'll proceed to our next second case.
Thank you, Dr. Collins. Uh, so the second case, I'll be just quick. It was an interesting case, a presentation of stroke. So we have an 80-year-old male presenting with tingling and numbness in the right hand with some weakness, which settled within few hours of presentation. And sorry, it's lasting up to 4 to 6 hours in the right arm, not arms. He also felt some pain in some weakness in the right leg, which was not demonstrable on initial clinical assessment. Bloods and initial imaging was unremarkable. What investigation to do next? There was no speech impairment, no other focal neurology, and our weakness had settled. So when it came to medical team, obviously they arranged a CT brain. I'm just sharing a few clips with you.
Right.
So rightly identified by one of our colleagues about on the left side, if you notice something here in frontal parietal lobe. And again, with effacement of ventricle here. So now, just for my junior colleagues and my colleagues, can this be a bleed? Can this be a bleed, or is it a mass with a vasogenic edema? So if those people who are saying it can be bleed, and I say it's not a bleed, and I discussed it with radiology consultant, why is that? So just a learning event here. Just if you see the outline here, and if you see the architecture of brain is pretty much preserved with sulci and gyri, and is quite clearly demarcated. There's some vasogenic edema. However, this is a mass with vasogenic edema. There's no bleed. However, yes, we do consider masses can have also bleed associated with bleed. So this was naturally not stroke. CT was reported as having 1.9 to 2.1 centimeter mass lesion in the superior left frontoparietal lobe with extensive perifocal edema. If you recall, the patient presented with right-sided symptoms of weakness and some attenuation of low attention and attenuation foci in both ganglia as well. There was no evidence of intracranial hemorrhage or extra-axial collection, and appearances were in keeping with brain tumor. We arranged an MRI, had involved the oncology team, and these are the findings for MRI. I'm just sharing a few clips with you. I think it's very apparent here now. It's quite a large tumor with effacement of the ventricle as well. Some vasogenic edema there. So MRI confirmed that there is a left cortical base parietal lesion which measured up to 2.5 centimeter diameters, and they was a presence of vasogenic edema. So what to do next? We also noted that patient was on apixaban for PAF. So would you continue this? Rightly so. One of the colleagues said not to continue this, but we often see this, and this is just for learning. One of the learning outcomes from this is that we often see that patients who have been who are bedbound and who have been diagnosed with tumor with no bleed, the Pixaban has been withheld, but often we note that some junior colleagues or some colleagues would often put a low dose Clexane, 20 milligrams, just as a VTE prophylaxis because there's such a high risk. A patient having cancer and patient is bedbound. And if you withhold anticoagulation, then that means the patient should not have chemical VTE prophylaxis, and that should be very clear. And we have noted that before as well. It stop presenting. Something happened. Can you guys still hear me? Okay.
Yeah.
Okay. Thank you very much. Sorry, it's just showed here. Stop presenting somewhere. Yeah, I can move the slide. So that was one. So we obviously withheld the Pixaban. We involved oncology team, and we also noted that during inpatient stay, patients started having some focal seizures, again involving his right arm. There was no loss of consciousness, and it was not generalized tonic-clonic. So what to do next in management if we know that patient has some tumor in the brain, we know has been anticoagulated, which we withheld, and patient is now having seizures. So obviously, we have to manage both, isn't it? So with the help of oncology team, we started the patient on dexamethasone. The case was referred to neurosurgery. Seizures were controlled with after initiation with Keppra. Patient remained alert, responsive throughout with GCS 15 out of 15. No further focal neurology. Um, Anything else we need to do with this patient? Shall we just discharge with oncology and neurosurgical advice? So rightly said, we have to investigate further. We have to get a body scan, CT, chest, abdomen, pelvis, to ensure whether this is a primary brain tumor or it's a metastasis. And that we did. We did arrange a CT cap in this patient. So if you just focus here on the right side. So if you can notice something in the right lower lobe, there's evidence of some effusion and some mass there, which if I just show you some coronal sections, which is better appearing here, if I just go from back and forth, there. So it's actually quite posteriorly from the right lower lobe extending to right upper lobe and involve having some effusion as well on the right side. So the CT cap report was a necrotic mass within the superior segment of right lower lobe, extending into the left into the right upper lobe, which is evidence from here. And there was no mediastinal or halal lymphadenopathy, but the imaging was consistent with primary bronchogenic carcinoma, and staging was done. So we found out that the patient actually had a lung cancer primary with the metastasis in brain. So what are the learning outcomes here? So I'm just going to hand over to Dr. Collis.
So thank you. I mean, that's another interesting case here. And I think it's important for us to basically look, deeply, again, in this case, to see if there's any other reasons why this patient developed brain tumor. I mean, we could have stopped there, but we pursued to try to give a better picture of what's going on, and we did the follow-through investigations, and we found out that this patient had a primary lung cancer with brain mets. So again, obviously, it's important for us to look into things a bit in details, take our step back, and obviously try to understand what's going on. And this is what we did in those two cases. Obviously, the first case, we could have just easily discharged symptomatic treatment and take it from there. And also in this second case, we could have just stopped because we have already have known the conditions and explained the symptoms of this patient. But obviously, it's also important for us to take a little bit, time and obviously work our way through. And for us, it's always good to have this type of case presented for us to be reminded. And I think it's beneficial for everybody learning, especially from the medical field, as well as benefit for the patient. And it's easy for us to give the full picture to the family and course of the condition or the disease process. From the participants, any questions? Are you guys can still hear us? I'll give you back to Safe.
And just out of interest, just mentioning this last patient, we had a detailed discussion with the family and the patient, and it was decided that he did not want any further surgical intervention, and mutually agreed plan between oncology, neurosurgery, and the patient. The patient was discharged with palliative care support. Family was in agreement. There was no concerns. So if there's no questions, thank you very much for attending this grand round. I really, really miss our previous grand round where we actually see each other and meet each other in person. Hopefully, we'll do that soon. So have a good day, guys. Oliver, is that okay? Thank you. Thank you, everyone. Have a good day.
Thank you.
Yeah. So I told you 55 slides, 20